Good morning, ladies and gentlemen, and welcome to May the 4th. May the 4th be with you. Happy Star Wars Day to everybody. Let's start as we aim to go on. So this is the third day of National Thrombosis Week 23 virtual conference. It's been absolutely brilliant up to now, so I hope everybody's getting a lot out of all of the sessions and finding something that's useful for your area of care. We've had almost 2,000 registered delegates from 52 countries around the world, which is absolutely brilliant. It's really good to share the work and the news and everything that's happening in the work of thrombosis today. And today is the All Wales Showcase. So we're going to be showing you what's happening in Wales. And I'll talk about that a bit more in a moment. So we have a very packed and interesting planned, although virtual, chat and Q&A functions, and we welcome audience comments and questions onto the live sessions. I think the best thing to do would be to have question and answer session after each of the presentations rather than interrupting during. So if you've got any questions or comments, please type them and I'll pick them up as we go along. I'd like to thank the sponsors, and please take time to visit the exhibition hall where there are stands from sponsors and supporting professional bodies, providing the opportunity to chat, gather resources, view and network, and find out anything that you're interested in or questions that you've got that you would like answers for. You might also like to wander through the poster hall. This is new to National Thrombosis Week 23. Organisers have received some great submissions, and those selected are available to leave comments and view or message the author. So if there's something of particular interest there, whether you want some more information or whether you just want to give the person a pat on the back and say well done, then that facility is there. So as I said, we've got the All Wales Perspective today, and we're going to be kicking off in a moment with a colleague, Christine Welburn. But before that, just to let you know, Thrombosis UK is a national charity striving to increase awareness and education in all areas of thrombosis. National Thrombosis Week welcomes presentations and shared learning from individuals across the UK. We share effective practice, common challenges, and identify opportunities. And this morning, we, like I said, are focusing on the VTE perspective from Wales, where there have been significant changes taking place over recent years. So today, chairman with me is Marilyn Rees. Marilyn is the venous thrombosis research clinical nurse specialist. Up until recently, she'd been the lead in the UHW Cardiff DVT clinic, where she'd worked for some 10 years alongside Dr. Razar Ali Khan, improving and streamlining the assessment and management and follow-up of patients diagnosed with deep vein thrombosis. Marilyn's founder member of the All Wales Hospital-Acquired Thrombosis Steering Group, which you'll hear a bit more about later on. So without further ado, I'd like to welcome my colleague, Christine Welburn, who is the thromboprophylaxis clinical nurse specialist in Ysbyty Glan Clwyd, Beth Cadwaladr University Health Board in North Wales. As part of her role, she is involved with the identification and carrying out of root cause analysis on all hospital-acquired thrombosis. Her work has been nationally recognised, and she has received multiple awards, as well as gaining national exemplar site status for her health board. And Christine is going to talk about improving thromboprophylaxis uptake. Thank you very much, Christine. Over to you.
Thanks, Andrea. So my name's Christine. I'm the thromboprophylaxis nurse from Glan Clwyd Hospital in North Wales, and I just want to give you a quick update on what we've been doing across North Wales in improving thromboprophylaxis update. Sorry, my screen's not moving on. Oh, there we go. So first of all, I just want to recognise everybody that's been involved in implementing our Apple project. So I've got Mr. Hannah, who's our clinical lead for thromboprophylaxis in Glenclwyd, Dr. Mick Mwenda, who's the chair of our BCU HAT group and clinical director for medicine in Glenclwyd. There's myself as the thromboprophylaxis nurse, Heyman Chowdhury, who's our lead pharmacist for surgery in Glenclwyd, Joanna Swan and Lauren Williams, who's pharmacist in medicine in Glenclwyd, and Clinos Williams, who's our physician associate in orthopedics. And then we've also got our HAT teams in Wrexham Marla, which is Lisa Pemberton as thromboprophylaxis nurse and Dr. David Watson as the clinical lead. And then there's our HAT team in YG, which is Rhianwen Griffiths and Megan Jones, and their lead, Karen Mottart. And obviously all our amazing clinicians at BCU that without them, we couldn't implement it. So in 2017, we had a high amount of potentially preventable hospital-acquired thrombosis HATs and low compliance in completing VTE risk assessment tool. The causes of this was a lack of awareness of the importance of thromboprophylaxis, the lack of understanding of what a HAT is, the lack of feedback and lessons learned from root cause analysis, our RCAs, and clinicians didn't think it was a problem. We've had no thromboprophylaxis nurse in post prior to August 2017 for several years. There was also a lack of ownership and responsibility and a lack of education and support for clinical staff. Then from August 2017, a full-time thromboprophylaxis nurse was employed to support the HAT team. This was replicated across all 3 areas or hospitals in North Wales, which enabled a health board-wide approach. So the important thing, just to have a bit of background of our health board, is that we have one health board covering the whole of North Wales, which is a massive area. So it's split into 3 areas. So we have Central, East and West. And so what we've done is we've got a thromboprophylaxis nurse now in each of the areas, because it's such a wide area to cover. Even if it's separated in 3 areas, it's still a massive area. So the work we did to solve the previous issues we identified was we had a HAT and VTE training sessions given to all doctors on induction every year. We had training and lessons learned given to all departments in the clinical governance and grand round meetings. We had the HAT and VTE training given on a monthly basis to nurses, doctors and pharmacists. We had guidance on ownership and responsibility for all disciplines, and we had regular audits and quality improvement projects, including commencing our thromboprophylaxis walk-around to give real-time feedback, guidance and education to both clinical staff and patients. So all these improvements led to a dramatic increase in our compliance in completing the VTE risk assessment tool from 20% in medicine to 40% in surgery up to 100%, and a massive decrease in our potentially preventable hospital-acquired thrombosis from 22 in 2017 to 4 in 2018 to 0 in 2019. And we actually had 18 months of no preventable HATs in BCU. And then 2020, the COVID-19 pandemic hit, so our HAT service was suspended. And then 2021, our HAT service resumed. So once we started doing the catch-up of all the root cause analysis, all our HAT data, and finding out what our lessons learned was and what the data was, the results show that during the COVID-19 pandemic, without the education and support from the HAT team, the compliance in completing the VTE risk assessment tool decreased, and our potentially preventable HATs did increase. So this change in compliance indicated that, coupled with the pressures of the COVID pandemic, whilst our thromboprophylaxis walk-around did improve compliance and sustained our target result levels, it still remained reliant on the HAT team to drive it. This is what came apparent from all the lessons learned that we had over 2020. So therefore, we decided that a new approach needed to happen alongside our thromboprophylaxis walk-around. So this is what we came up with, the idea of our Apple, and we incorporated that into our thromboprophylaxis walk-around in order for all the clinicians to take the ownership of the work. So this is our Apple approach. So we created this Apple approach, one, to improve our compliance and reduce our preventable HAT data again. Secondly, most important for patient safety, and also to achieve the recommendations set by the Welsh Risk Pool, who's governing us now. So APPLE is our acronym for our MDT approach project, and it stands for the first A is for the assessment. So that's our VTE risk assessment in our clerking performer, and this should be completed on admission by the clerking doctor. P is for peer review. So we're asking all our consultants to now check whether the risk assessment has been completed and the prescription's being prescribed properly on the post-take round, and if not, make sure it gets completed and any prescriptions corrected on that point. The second P is our pharmacy check. So this is where all our pharmacists on the wards and the admission areas are checking also that the risk assessment's been completed, the prescription's been prescribed and correct, and if not, to get it corrected then. L is for leaflet for patient. So we've had a big drive on making sure all our patients get the VTE information leaflet given on admission, so they're aware of the signs and symptoms of VTE and also why thromboprophylaxis is important. And E is for education. So this is to educate both staff and patients on thromboprophylaxis and VTE symptoms. And this has been one of the key areas that's really improved things, because people are passing on the knowledge, passing on, if somebody doesn't realise what they should have been doing, they can pass that on. It's empowered patients to start being involved in it now and asking questions about it and understanding why they're having the thromboprophylaxis. And it's also education about the nurses, because we've had a recent problem with missed doses, so it's education regarding that, so the nurses are more aware, especially we have agency nurses, that they can check and give that support as well if they haven't had the training. So this is what we've been targeting over the last over a year now. So at the bottom, we have our VTE prophylaxis box in our All Wheels medication chart. The middle picture is our version of the Apple checklist that we do in our walk around, which is our audit tool. This has changed over the last years because we've done several PDSA cycles changing it, but this is our current version of what we use now. And then on the right, there's our front sheet of our medication chart. And then what we ask the nurses to do once they're given the leaflet, we stick a sticker on that just to make sure that everybody's aware that the patient has had the written information as well as verbal information. And all this came around from our lessons learned, where we identified that there was several missed opportunities on some of our preventable HATs. And if we all work together as an MDT approach, then these opportunities can be set as safety netting and be caught in time on admission. So this is our effect on our potentially preventable HATs. So back in 2017, when there was no HAT service, we had 22 preventable HATs. In 2018, once we did have a HAT service and we started our thromboprophylaxis walk around, we decreased that to 4 potentially preventable HATs. And then 2019, we had 0. And then in 2020, once COVID pandemic hit us, our HAT service got discontinued for a while. We increased up to 9, which was a big jump for us. And then 21, when the HAT service did come back in and we started our walk arounds again, but was quite bogged down with all the backlog of RCAs and lessons learned to sort out, we decreased to 7. And then once we started our Apple approach, it was early days in 21, and then it really took off last year. We've gone from 7 to 3. So this is how it's affected our compliance. So in 2019, prior to the COVID pandemic, we was 100% in our VTE risk assessment compliance. And then during the pandemic, it averaged around about 80%, but some areas, especially emergency medical admissions, they dropped down to 20%. In 2021, due to all the walk-arounds, education restarting, it did go back up with an average of 95% in most areas. And then in 2022, we have an average of 100%. Occasionally, a few areas do dip below that, but we tend to be over 95%. Our potentially preventable hats, like I've just explained, have decreased. So it was 0 in 2019, did have a massive jump to 9 in 2020, and then it decreased from 7, and then but with our Apple approach over the year, it's decreased to 3. And then the last graph is the dark blue line is our thromboprophylaxis prescribing, maintained above 95%. Now that's constantly over 95%, even during the pandemic. But what had happened is we've had several missed doses or incorrect prescription prescribed. And that's what led to our preventable hats. And then the green bar, that's our compliance with giving out the VTE leaflet on admission. So prior in 21, it wasn't like it was about 30%, and that was mainly surgery that was handing it out. But over the last year or so, during our Apple education, we've managed to achieve 100% now. So it's incorporated in our nursing packs. And when the nurses do their clerking in, they just give the VTE information and put the sticker on the drug chart as they're doing their clerking process. So on evaluation, our Apple data is not yet complete. However, data so far is proving quite positive. So the pros is that our lessons learned identified the 4 opportunities to ensure that VTE risk assessment was completed and the appropriate thromboprophylaxis was prescribed. The MDT approach increases the likelihood of best practice. Our results so far is showing a positive impact on practice. It incorporates VTE information given to patients and encourages patient participation in the care and patient's compliance with having the thromboprophylaxis. This is particularly important for when they have extended thromboprophylaxis, because sometimes they don't want the injections and they don't use it once they get home. So this is improving the compliance after they leave our care in the hospital as well. MDT approach prevents dependence on one person or service, like we saw when the pandemic hit. We came back and everything had decreased because we wasn't there to help support and drive it. It doesn't actually cost any additional money to implement if you've already got clinicians there in place. We haven't spent any money in our health board doing the Apple approach. The cons to this approach so far is been very time consuming. We need senior lead clinicians complete the Apple thromboprophylaxis walk around with the thromboprophylaxis nurse. We do a lot of auditing, a lot of analysing the data. So it is very time heavy, and it's quite hard as well to get all the senior clinicians available on the same day, on the same time. So it's quite a lot of organisation that goes into it. And it also relies on senior clinicians and also the hospital management team to buy into the project. So without the clinicians buying into it, our Apple approach can't really go, because it's dependent on the juniors, the seniors, the pharmacists, the nurses. So it really does need to be MDT approach, otherwise it won't get as good effect. So this is some of the changes we've now got in practice over the last couple of years. We've now got an all Wales thromboprophylaxis policy, which has been really beneficial to have an all Wales approach. We've got our BCU thromboprophylaxis dosing guideline, which is based on the weight in EGFR and what to prescribe. We've got our BCU MIU PGD for thromboprophylaxis in minor injury units. We have the minor injury units, emergency department and fracture clinic risk assessment for lower limb injuries. We updated this recently to incorporate the TRIPCAS score, and we've just been doing a lot of evaluation on it, and it seems to be working really well. And so again, we've added make sure the patient gets information on that, make sure everything's supplied, sense taking, and it's really showed better compliance in thromboprophylaxis, particularly in the minor injury units and fracture clinics, and patient compliance and more appropriate thromboprophylaxis in prescribing. We've also updated our hospital acquired thrombosis page on our BCU intranet. So this is a new page on there, which has been really handy for clinicians to find exactly where the risk assessment side they want to do a reassessment, all our policies and guidelines, all our improvement projects, everything's on there. And then we've updated our theta safety checklist, so that now has thromboprophylaxis on each section, and that's really decreased the amount of surgical hats that we've been getting, especially from day cases and things like that. We've obviously done our Betsy Apple walk around, which is going really well at the moment. Again, we haven't finished the whole data collection for that, but it's looking quite positive. We've got the All Wales e-learning VTE package, which is amazing. So we're in the process of trying to get everybody to switch over to that. And so we're swapping that. We're still giving individual departments extra training if they want it specific for their area, but we direct everybody to this e-learning package first. And then we've also got our mechanical thromboprophylaxis SOP as well. So BCU HAT group is currently reviewing our practices and processes relating to thromboprophylaxis and HAT. We've got a number of changes underway, which include we're now switching over to electronic record keeping. So the Clarkin book is being made electronic, and that should be out. It should have been this month, but I think it's going to be next month now. And we've asked for our VTE risk assessment to go mandatory, so we know that the compliance will be there. The electronic RCA's process for our HAT with electronic dashboard. So we've already switched to electronic processing for our RCAs, and we're just in the process of creating the electronic dashboard. So we're not doing it manually and sending it out manually. It'll all be there. Our VTE risk assessment for lower limb injuries is going to go again. Symphony is our electronic version for all the minor injuries and emergency departments. So that'll all go electronic as well. Our self-assessment audits for our wards. So this is to go alongside our Apple walk around. So we'll get the wards to start auditing themselves and take the responsibility for it to make sure even if our HAT service does get stopped for whatever reason, if another pandemic or something happens, then at least the wards will still be doing that and it'll take ownership, so we won't have the same problem as we've just had. We've had several improvement projects and audits going on in various areas, and we're gaining a lot more VTE champions, both in medical, nursing and pharmacy staff. So really our take-home message is that improvement work done in BCU has shown that it's beneficial of having a dedicated thromboprophylaxis HAT team. Achieving best practice and patient safety really needs to be the MDT approach, and sharing experience and improvement projects can be replicated across sites to improve patient safety, as we've done across BCU. So we started our Apple approach in Glenclwyd, and now Wrexham and YG are also starting to complete that as well. So we do tend to share best practice across BCU sites, and then once we've got that up and running and it is looking like it's working, we can share it for the rest of All Wales groups then. That's it. Thank you for listening. That's my email if anybody wants to contact me. If there's any questions, I'm happy to answer.
Thank you very much, Christine. Excellent presentation there. And just to say that Christine, along with our other speakers today from Wales, are all members of the All Wales HAT steering group. And the presentation that Christine has just given us, when we meet as a steering group, we present, or each of the health boards present back in a similar sort of way to the way Christine has just presented, to give us uptake figures locally of thromboprophylaxis risk assessment and HAT rate, and also changes that are happening which are beneficial to patient care and sharing good practice. So thank you for sharing that, Christine. That gives a really good vision of what we're aiming to do in Wales. So does anybody have any questions, please? I do have a question here. The All Wales VTE training address, please. Yes, we can share that with you. We'll send that on to you afterwards, although I'm not sure that you'll actually be able to access it unless you're on ESR. It's embedded in the ESR programme. Marilyn, do you know if you're able to access ESR, the Welsh modules from outside of Wales?
I don't think so, no. You have to be in Wales. I think. I'm not 100%, but we can check.
Yeah, if we can send it to you and you are able to access it, then we will send it. If not, I suggest you contact M&G in Kings, because there is also, I think it's a web programme, education programme, which you can access, and Emma will be able to give you some information on that. So, no other questions here. There was a couple of things I wanted to comment on, Christine. One was your Apple acronym. Excellent, really good. Did it take you long to come up with that?
To be fair, myself and Dr. Kumwanda came when we was doing our walk around, was trying to identify which is the areas that we needed to concentrate on for the safety netting. And then Dr. Kumwanda said we need an acronym. And then that just fell into place. But then we didn't know whether to call it Betsy Apples or something like that, so we didn't get in trouble for Apple. So we just stuck the apple on it, and so it's not Apple.
No, I like the Betsy apple. That's good. We'll have to talk about that at our next meeting. The VTE sticker on the med chart, again, good idea. As we are now going to electronic prescribing and electronic record keeping, then hopefully you'll be able to replace that with an electronic sticker, which I
hope so, yeah.
Obviously be a lot easier for the nursing staff. And again, multidisciplinary approach, so important. And we've found this over and over again, taking the multidisciplinary approach to achieving the uptake of thromboprophylaxis, to reduce your hospital-acquired thrombosis rate, absolutely essential. I think the work you've done in Betsy is brilliant, so well done. And thank you for your excellent presentation. Now, I just have another question. How do you tackle the issue of bank and agency staff and compliance with administering prophylaxis? And that's from Susan Kittaker.
That's the problem that we've faced last year. So the majority of our preventable hats from 22 came from agency nurses not administering the thromboprophylaxis. So we've got a bit of a drive going on at the moment, where we're asking our own staff who's on the ward with the agency to make sure at the end of the shift, now that they're checking that it has been given, making sure that they're aware. And I believe that also making all agency staff that's coming to the health board now to do the e-learning training and to make sure that they're up to date with what they should be doing with the thromboprophylaxis. And that's gone through our nurse education team. So on induction, before they're allowed to start our shifts now, we are asking them to complete the e-learning and make sure that they are aware that this has to be given. It's a critical drug. You can't keep missing it.
Yeah, that's absolutely true. And it's interesting because, again, when presenting from each of the health boards in Wales at our steering group meetings, we identify what are common issues and challenges. And one of the things that, as you know, both Christine and Marilyn, that has come up has been where agency staff have been employed and there have been omissions on the dosing, or sorry, the administration of thromboprophylaxis. But hopefully with the advent of the electronic prescriptions and medication charts, that will come to an end. We shall have to watch and wait and see.
Yeah, another thing we're working on with that is that we have the Medi-Wells, and so we think it's a problem of them going back and forth. So we're going to try and do some pilot with that. So we don't know whether it's the access to the thromboprophylaxis or if they just get fed up of walking up and down to get it, or we're not sure. But there is definitely an issue with that because they don't get the same amount of support that we give our ordinary staff, because we always see them there, and then often on night shifts and things where we're not there. So it is an issue that needs looking at, but I don't think you're alone in that. I think a lot of people suffer with that because we've depended quite heavily recently on agency.
Yeah, okay. Right, I'm afraid we don't have any more time now for questions and answers, but if anybody's got a question specifically for Christine, you can contact her directly or go into the lounge and into the chat rooms on the virtual conference page, and hopefully you'll be able to get any answers there for questions you've got. So moving on now, our next presentation is from myself and Marilyn Rees, and we're going to look at hospital-acquired thrombosis from an all Welsh perspective. I'm the lead advanced nurse practitioner for anticoagulation in the Princess of Wales Hospital in Bridgend. I'm also Wales Nurse Director for Thrombosis UK. And like Marilyn, I'm one of the founder members of the All Wales HAP Steering Group. So we'll go through our presentation now, and if you have any questions, please ask away and we'll answer at the end. So thank you. So Wales as a nation forms part of the United Kingdom, and as we all know, the United Kingdom is made up of 4 separate countries: England, Ireland, Scotland and Wales. We focus on Wales. There are 3 million people residing in Wales. We have our own language, the oldest language in Britain, and it's encouraged to be spoken. If you visit Wales, you'll see everything is bilingual, which can be quite challenging if you don't understand Welsh, but also quite interesting as the language is very beautiful when spoken and even nicer when it's sung. There are more sheep in Wales than there are people, approximately 10 million. The economy includes agriculture, industry, manufacturing, steel and aerospace, and service sectors such as tourism. The geography of the country is varied with mountain, sea and pasture, so there's something for everybody if you choose to visit. Rugby is the national sport, sometimes maybe football.
Quite often.
Yeah, for those of you who've been watching the telly recently, you'll have seen the success of Wrexham, who have really hit the headlines and doing amazingly well. So go Wrexham. And we have a unified approach to reduce the number of hospital-acquired thrombosis, which is what we're going to talk about today. So in Wales, there are 7 health boards and Velindre Cancer Care Centre. So we've got Betsy Cadwaladr in the north, Powys, which forms down the east side of Wales, Haldar and Swansea Bay University Health Board, which are to the west. And then in the south, Cwmtaf Morgannwg, and Iron Bevan and Cardiff and Vale. And adjacent to Cardiff and Vale, we've also got Velindre Cancer Care Centre, which is just outside Cardiff. Thanks, Marilyn. So just to give you a bit of background, in 2012, approximately 900 people in Wales were reported with dying from venous thromboembolism related causes. Not all of these deaths were avoidable, but many may have been. And many survivors of deep vein thrombosis suffer long-term physical and psychological effects. Most cases of VTE occur during or following a hospital admission. For those of you who have been staying with the conference all week, you would have seen Paul's presentation, I believe it was yesterday, the psychological effects of suffering a thrombosis, and really interesting. If you get a chance to go back in and watch his presentation, I think you'll be quite surprised, because I think sometimes the long-term psychological effects of suffering a VTE are possibly underestimated. And his session is really important and really interesting. Thank you, Marilyn. So VTE can have long-term effect on survivors. So as was just saying, with physical and psychological symptoms. So up to 40% of patients can develop a chronic condition called post-thrombotic syndrome. And research completed in Wales identified psychological complications with some symptoms suggestive of post-traumatic stress disorder. Most cases of VTE occur following a hospital stay, and these are known as hospital-acquired thrombosis, or HAT. Most of these cases can be prevented with simple preventative measures, early risk assessment, and appropriate thromboprophylaxis. So the national recommendations in Wales were made following one-day inquiry by the Health and Social Care Committee, Welsh Government, in 2012. And the Welsh Government issued recommendations to NHS Wales to encourage improvement. These recommendations were making reporting of HAT a Tier 1 priority, mandate risk assessment and thromboprophylaxis, develop a standardised HAT rate, undertake root cause analysis of all potential HATs, and increase clinician and public awareness. Now, at the same time in England, you had the sequin payment, and the uptake of thromboprophylaxis risk assessment determined what sequin payment health trusts got in England. We never had such a payment in Wales, and so Tier 1 priority was highlighting the mandating of needing to do the risk assessment and the thromboprophylaxis prevention. So basically we had a carrot and a donkey and a stick. But I think you'll find that we did quite a lot with our donkey. Thank you, Marilyn. So the All Wales HAT Steering Group was set up to implement the recommendations from the Welsh, made by Welsh Government. And the group includes a multidisciplinary membership from all 7 health boards and the Cancer Care Centre in Wales, and also includes clinical trustees and patient representatives from the renowned thrombosis charity, Thrombosis UK. So the steering group agreed the definition for HAT and a methodology for collecting potential HAT incidents. Importantly, they recommended changing the reporting measure from a HAT rate to HAT incidents. So what we wanted to show was that for each health board, the actual number of patients. So we took the number of potentially preventable VTE events, extrapolated the figure through doing root cause analysis to demonstrate the actual number of preventable hospital-acquired thrombosis events we actually had. So instead of having a percentage, we actually had a figure. And I think with having a figure, we could relate that more to the person rather than to just a number. The group developed an agreed risk assessment process working in collaboration with the All Wales Medication Chart Group, and this resulted in a new section being added to, at the time, the front page of the All Wales Inpatient Medication Chart. And that made it easier to ascertain whether patients had been risk assessed and whether the correct thromboprophylaxis had been prescribed. Now, tied in with that tool that was put onto the All Wales Medication Chart was there is a thing in Wales called the hospital thermometer, and pharmacists collect data on the wards off of that chart. And one of the things that we had put onto their audit collection was the uptake of the completion of that risk assessment box. So it also meant that we were able to get an All Wales figure and locally at each health board of what the uptake of thromboprophylaxis risk assessment was. So not all VTEs can be avoided, and the group wanted to create a measurement system that identified those potential cases that could have been avoided if the correct steps were followed. And therefore, a screening tool was included in the reporting mechanism. And as I said, potentially avoidable HATs were identified by asking 2 simple questions. Was a VTE risk assessment carried out? And was the appropriate thromboprophylaxis given? If the answer to either question was no, then the case needed to be investigated further. So in 2015, the method for recognising potential hospital-acquired thrombosis was linked into Welsh Government's Tier 1 reporting mechanism, where health boards were required to report the number of potential HATs identified monthly, the number of HATs that were potentially avoidable quarterly, and the lessons learned from a subsequent root cause analysis that was carried out on every patient that was identified. And this was the tool that was developed by Welsh Government at the time in conjunction with the All Wales Steering Group. So as you can see, I'm afraid it's not particularly big, We had the, on the left-hand side, you've got the number of cases, and these were the actual VTEs that were reported month on month. Now, that wasn't every single VTE that was identified in the health board. These were VTEs that were identified either during a patient's admission or up to 90 days post-discharge. And we had a set of criteria to identify the patients that we actually wanted to identify, although you find that there are absolutely hundreds of patients to go through to extrapolate those who have potentially developed VTE during their hospital admission or up to 90 days afterwards. So we collected those figures monthly, and then those figures were looked at then quarterly, and the root cause analysis was carried out to establish whether or not those patients had been risk assessed, had those patients been given appropriate thromboprophylaxis, and going through a process of root cause analysis and asking appropriate questions, we could identify that from those monthly figures, how many of those patients were actually preventable hospital-acquired thrombosis, potentially preventable. And this figure then was, all of this data was sent back then to Welsh Government, and reports were produced for Welsh Government and sent back to the All Wales Steering Group and back to each of the health boards. We then met as a group to discuss the findings and to continue to improve practice to improve the situation. So the greatest improvements were made in the promotion of reporting, reviewing and reacting to the potential HAT incidents. Every health board collected and reported the potential HAT incidents to Welsh Government, as I've said, and they reported how many of these incidents had been root cause analysed and what the lessons had been learned. Analysis showed that this had also had an effect on the increasing number of assessments performed in a virtual circle that could result in the number of incidents decreasing. And again, all of this information we brought back as a group, and it was reported on paper electronically, but we also had the opportunity to discuss it face to face and look at what common themes were with incidents, which is where we identified that one of the most common themes was the missing of giving actual thromboprophylaxis to patients, which involved bank and agency staff. So the positive approach of Welsh Government and NHS Wales clinician working collaboratively to improve patient safety has been presented to other countries in the UK and has been recognised as good practice. We've travelled to Scotland and to Ireland, and through National Thrombosis Week, prior to the format that it is now, Thrombosis UK used to hold meetings during the first week in May in Ireland, Scotland, Wales and England, encouraging those countries to improve their uptake of thromboprophylaxis and reduce their hospital-acquired thrombosis. So we demonstrated standard practice in Wales with the implementation of the amended All Wales medication chart in 2016, which has led to an increase in the number of assessments undertaken in Welsh hospitals. And this was identified as a key process step that can lead to the reduction of hospital-acquired thrombosis. Thanks, Marilyn. So prior to 2016, we had the VTE risk assessment box, which was completed by clinicians. It was agreed in 2014 that the risk assessment would be embedded in either the clinical Clarkin booklet as a memoir or as a reference, and then the completion of the dosing of thromboprophylaxis and identifying that a risk assessment had been completed or acknowledged, and whether thromboprophylaxis was to be given or not, was added onto medication chart in 2016. And I really like this chart because this reflects the chart that Beverly gave in her presentation on the very first day of this conference, where she showed the national downturn in the number of potentially preventable HATs. And I'm really proud that we can show the same in Wales, that we also have a downturn in the number of potentially preventable HATs. due to the work that has been done across the country. Now, on the chart on the right-hand side, as you can see, shows the increase when the VTE risk assessment box was placed onto the medication chart. So we can show that in 2016, we started to show a downturn in hospital-acquired thrombosis, and post 2016, we show an increase in the number of patients that were risk assessed, and that was documented on the medication chart. And again, this figures are available for each health board individually, but also on an all Wales level. So that's really important to us because we can gauge how we are doing as a nation. Thanks, Marilyn. This was a screen that was used in ABMU, as it was. The rather jagged red blue line at the top shows that was the number of VTEs that were identified in the health board within 90 days of discharge or during admission. And then the blue line and the red line, they show the uptake in thromboprophylaxis, risk assessment, and reassessment. And at the bottom, you could see VTEs by speciality and by procedures, and also by site and by ward. And we could get information from this, this page, looking at where there were areas of concern, looking at if there were specific specialities that were of concern. And we could also look at what our month-on-month uptake of risk assessment and reassessment was. So that was an important tool for us in ABMU. And again, going back to 2012, this chart starts. This again is ABMU. You can see the uptake improved dramatically from 2016, and the blue and red lines are risk assessment and reassessment of thromboprophylaxis, and a downturn is the green line. And again, the an Iron Bevan chart, which is on the right-hand side. And again, that shows in 2016, the compliance using the medication chart, VTE risk assessment tool in conjunction with the VTE risk assessment, the full assessment, which was in the patient's notes as a reference. Thanks, Marilyn. So now in Wales, same as everywhere else, we are going back to using a full risk assessment tool. This is a generic risk assessment tool that we've developed in Cwm Morgannwg University Health Board. It's all-encompassing, and it's got absolutely everything on it to cover risk assessment, treatment for patients, for medical patient risk assessment, surgical patients, also for extended prophylaxis. It's been piloted at the moment, and we're going to review it in July to see if what the uptake is. But I'll come back to that in a moment, what the plan is with that. This is a reassessment tool that is used in Swansea Bay University Health Board and in the Princess of Wales Hospital. And this was rolled out to demonstrate reassessment for patients during their hospital stay. And so we were able to give a figure. This was tied into the care matrix system, which is a system of demonstrating quality on the shop floor. And we were able to demonstrate the uptake of this reassessment tool, again, month on month. So that's been really useful. So thrombosis prevention work presented globally has put Wales on the world map. And we do like to spread the word because there's been so much work done, and we think it should be out there and the world should know what we're doing. So in 2018, following the publication of the revised guidance on thromboprophylaxis, which is nice in G89, CG89, the All Wales Heart Steering Group led the development and agreement of an All Wales thromboprophylaxis policy. And Christine alluded to that in her presentation. So the Thrombosis Committee representatives from all the NHS Wales health boards came together to ratify the policy at the end of 2019. And I believe in Wales, we're the only UK country to have done this. Because of the onset of COVID, we did manage to get the policy out in February 2020. So it was released just before COVID hit. And the effective changes were impressive in terms of the increase in VTE risk assessment uptake and the downturn in the number of potentially preventable HATs. Since the beginning of the Welsh Assembly Government HAT root cause analysis project, and this tied in with now we have an all Wales thromboprophylaxis policy. It sort of brings everything together, so we know we're all singing from the same hymn sheet. So the lessons we've learned: collaborative working between government and clinicians can result in sustainable nationwide improvement. Some organisations that have identified HATs that were potentially preventable and pinpointed area of learning so that a future delivery can be improved. And that's been really important. To ensure that organisations can benefit from this learning and to prevent their similar incidents going forward, details of individual health boards, lessons learned and corrective actions are provided in text and disseminated in the annual report delivered to all HAT leads. And the submission of incident reports has generated discussion amongst consultants, resulting in improvements in prescribing and documentation. Unfortunately, in October 2021, the NHS delivery framework for 2021 did not include the following measure: the number of potentially preventable hospital-acquired thrombosis. So basically, we lost our Tier 1 status, which at the time was, well, devastating, really, because although we've done so much work to embed the uptake of risk assessment and root cause analysis and the identification of hospital-acquired thrombosis, this work is ongoing and it needs to be sustainable. So we were rather concerned what we were going to do. So as I said, the consequence of losing the potentially preventable HAT as a Tier 1 priority was a serious setback. We didn't have the same financial initiatives which had been in place in England with sequin payment, and the All Wales Steering Group existence and all the good work we've done was in jeopardy. So the Welsh Risk Pool was established as a mutual pooling system to reimburse losses to NHS organisations in Wales, and they came to our rescue. In addition to reimbursing losses in NHS organisations, it supports healthcare organisations in establishing systems and processes to manage risk and reduce the incidence of losses. So in 2021, Welsh Risk Pool, following a number of patient claims associated with VTE, completed an audit of all Wales health boards to establish the uptake of VTE risk assessment on the full NHS style thromboprophylaxis risk assessment tool. It established that where patient claims were, where a full risk assessment was not completed, regardless of whether the patient was treated appropriately or not, judgment was likely to go in the direction of the claimant. And I have to say that this was not something that we'd agreed to in Wales, and we were audited on what was happening in England. So got together with Welsh Risk Pool and had a meeting with them. Thanks, Marilyn. A chance conversation came up where it was found that we could work together to achieve the same outcome. So what we found we wanted to do was improve patient safety, reduce mortality, increase the uptake of the full TP risk assessment, as was their wishes, improve TP education in all Welsh health boards, and reduce the number of claims associated with VTE. So the way forward for us was, due to the All Wales Steering Group Association with Welsh Risk Pool, we are now re-affiliated to Welsh Government through Welsh Risk Pool, which is actually better for us because it gives us extra teeth, so to speak. The Welsh Risk Pool standards of reporting via governance in each health board are set in conjunction with the steering group. So it means that we continue to have a voice and we direct the work that needs to be done and face the challenges together with Welsh Risk Pool, who have come in as a very good resource and support. The VTE Prevention teaching programme has now been launched on the ESR, which is the electronic staff record. And the ESR is a fully interactive system allowing staff to book classroom-based learning and undertake e-learning and monitor their own compliance. So the reporting standards include the percentage of uptake of VTE teaching on ESR, the uptake of potentially preventable HAT reporting, and uptake of thromboprophylaxis risk assessment completion on admission. So what we've done now is we've joined with Welsh Risk Pool. The All Wales HAT Steering Group have come together and have worked with Welsh Risk Pool to develop a new set of compliance measures, and these are the new recommendations. So all health bodies within NHS Wales will adopt the All Wales thromboprophylaxis policy, which has been done across the board. All clinical staff will undertake the All Wales training, both in relation to the recognition of patients presenting with symptoms of VTE and the prevention of HAT. The uptake of completion, which was initially set by the All Wales group at 50%, is due to be reviewed in July 2023. Patients will receive a documented VTE risk assessment using the Department of Health risk assessment tool or similar to assess each patient as soon as possible within 14 hours after admission to hospital or by the time of their first consultant review. And uptake of completion, again, is initially set at 50%, and this will also be reviewed in July 2023. An All Wales checklist for the investigation of HAT is under development in order to maintain a uniform investigation approach across NHS Wales. And VTE risk assessment compliance data and HAT data will be reported locally each month to clinical governance and Welsh Risk Pool. And health boards who do not achieve the standards set will not be reimbursed by Welsh Risk Pool in the event of a successful patient claim. So now we have teeth, we have big teeth, because finally Welsh Risk Pool have come along like knights in shining armour and are supporting our plight, and the work we've done now is being further supported by them, which is really good news. So the future looks bright. The All Wales HAT Steering Group and Welsh Risk Pool working together to help cement changes required to continue to reduce the risk of patients admitted to hospitals developing potentially life-threatening VTEs. Diolch yn fawr. Thank you very much. To welcome Dr. Annette Snell, who's a consultant ortho-geriatrician and joint hospital director at Bronglais General Hospital. Annette has worked closely with the Health Board Quality Improvement Team to review cases of suspected hospital-acquired thrombosis, designed an audit locally, and with the QI team, developed audits on completion of thromboprophylaxis risk assessment and appropriate prescribing for her health board. Presenting with Annette is Emma Phillips, who also works in the Quality Improvement Team and is QI practitioner for hospital-acquired thrombosis. Her role includes strategic responsibility for HAT quality improvement across the health board and quality improvement responsibility for all quality indicators across 2 acute sites. They're going to be talking about the challenges of implementing completion of thromboprophylaxis risk assessments across different sites in a health board. So over to you, ladies, and thank you very much.
Thank you, Andrea. I'll just get the slides up there. Hopefully, can you all see the screen?
looking good.
Okay, thank you. Okay, well, thank you for the introduction. And so, as mentioned, I'm Dr. Annette Snell. So I'm actually an orthogeriatrician and I'm joint hospital director in Bronglais. And my role is I mainly work with my orthopaedic colleagues, but I do general medical on calls, and I've also covered medical support for the surgical team. So I've ended up sort of linking with thrombosis as a non-hematologist.
And I'm Emma Phillips. I'm a quality improvement and service transformation practitioner and registered nurse, and I look after the hospital-acquired thrombosis for the health board.
Okay. And I'll tell you a little bit about the challenges. Because Hywel Dda is 4 acute general hospitals. So Bronglais Hospital, we haven't put the hospital on the map, but if you can imagine, is at the very north of the Blue and North Ceredigion. And then we have Withybush in Pembrokeshire, and in Carmarthenshire we've got Prince Philip and Glangwili Hospital. And although we serve a population of 384,000 in the area that's shaded, my hospital in Bronglais, we also have patients admitted from South Gwynedd and Powys, because we're the nearest hospital for an hour and a half for the rural area. And the area covers not just rural population, but also more densely property urban. So we've already mentioned our roles and things generally. And I suppose I'll start how I started in this, because it's been an ongoing journey, and I'm sure it's the same for many of people involved today. And certainly been a big part of trying to promote things as a non-hematologist for over 10 years now. And it all started back in 2011, and as I'm sure you're aware, the advice was at that point that each patient needed a careful risk assessment before prescribing any thromboprophylaxis. And I wasn't involved with this, but we had 5 forms arrive for thromboprophylaxis to all the wards, and we put them up as a very colourful display across the board. And I will talk about the issues we had with having 5 different forms, but we had the green form was our medical one, where we had a risk assessment. We didn't need to do the anti-embolism stocking assessment for medical patients, and the drug of choice at the time was enoxaparin. Compared to surgery and orthopedics, who had 2 forms. We had a form for emergency admissions and one for elective admissions. And for surgery, the drug of choice was tinzaparin, which was 3,500. And for orthopedics, it was 4,500. And again, they had a separate elective and emergency admissions form, because again, it was tailored to the type of patient being admitted. And on our forms at the bottom, we actually had advice of what to do if there was renal failure. And we didn't really have any guidance of what to do for extremes of weight, although the health board did have some guidance. So I saw these forms and kind of ended up, well, if no one, it mentioned about reviewing in these forms in 2013 and asked if anybody was doing an audit, to which the answer at that point was no. So I designed an audit just to look at the medical patients to see what was going on and whether or not we were actually completing the risk assessment forms, bearing in mind that this is supposed to be a standard practice since 2011. So I just looked at the medical patients, and there's just a little summary, I think, which is quite self-explanatory at the bottom, in that out of 47 patients, a lot were on anticoagulation for various reasons. 31 patients were supposed to have been risk assessed for thromboprophylaxis. And of those, only 7 patients had a risk assessment form, which was 23%. And I know, having presented this to my medical colleagues, there's a lot of backlash going, we don't need a form, we prescribe it, it's all fine, why do we have to have a form to prescribe safely? Well, part of that audit wasn't just about the completion of the form, it was actually, were we prescribing safely? Were we prescribing if there was a contraindication? And we were adjusting for weight or for kidney function? And out of those 31 patients, 1 patient was prescribed it despite an obvious contraindication. I recall they'd had a stroke, and this was pre our stroke unit. And we had a patient that was well under 50 kilograms of weight and given the wrong dose for their weight at that time. So I did present it to my colleagues. But also decided that probably the next best thing was see how everybody else was performing with completing risk assessments. So we repeated the audit and involved quite a few of the junior doctors across the specialties, and we decided that we'd do a monthly spot check to see how we were progressing. And we would randomly do 10 orthopaedic, 10 surgical, and we tried to do 20 medical because the vast majority of our patients in the hospital are medical and there's different specialties. And after my presentation, again, still not brilliant for medicine, on average, it's gone up from 23% to 38.75%. I was doing the spot checks for surgery in the orthopaedic team. Oh, it always had a missing form for some reason, and sometimes you knew the forms had been done and some of them had gone missing. But their prescriptions were, their risk assessments were between usually 70 and 90%. What we haven't put on there is actually when you broke down about the safety of prescribing, those that completed the risk assessment in 70 to 90%, mainly the surgical and orthopaedic team, had 100% accurate prescribing of thromboprophylaxis. So even if a risk assessment wasn't completed, because they were familiar with the process, the prescribing was safe. With medicine, at one point, we did identify that 12.5% of eligible patients for thromboprophylaxis were not getting their thromboprophylaxis. And again, in lack of completing the risk assessment, looking at the contraindications and appropriate dosing is an issue. And I do remember presenting that to my colleagues. And sometimes when you compare specialties, it can be good, because I know a reaction of some of my medical colleagues thinking that they didn't need them, that it was blatantly obvious that they needed to complete the forms and actually prescribe appropriately, and that other specialties that were outperforming them. And it is challenging, and I'll talk about the forms, because there's different forms, there's different doses, there's different prescriptions, the doctors rotate and prescribe from their previous job. It isn't easy with the forms that we had, and I have to be honest, a lot of people still complained about the format of the forms. I did take this to the Thrombosis Committee because I suppose being a non-haematologist on the ground, working with all three specialties in one format or another, I could feedback the problems we were experiencing. And part of it is, I think, sometimes clinicians' engagement in development of guidance, introducing guidance. And in this case, we had different doses, different drug preparations. And to be honest, ideally, we were hoping to get one form with, basically one low molecular weight heparin that was preferred, or a couple where you get the doses to make life easier, so that when you rotate around. But at the time, there were licensing issues that tinzaparin wasn't licensed for medical patients, and with cost issues, it was a drug of choice for our health board for surgery and orthopedics. So you can appreciate that having different doses, different preparations can be confusing. And having now had licensing changing in one form, which we'll come on to later, should have improved things. Having started this process off, this wasn't in our local hospital, this was taken over, and there were spot checks going on from the health board as a perspective across all sites. It can be challenging. I think having clinician engagement, such as the junior doctors collecting data and feeding back to teams, is something that we'll come on to, because we've gone back to, and then we'll come on to how we've gone back to doctors participation in collecting data, because if we're going to implement change, we do need to make sure we have clinician engagement in this, and as in particularly the junior doctors and senior clinicians trying to promote change, making sure things are done. Have we done this? And it needs to be a constant reminder, and it still is a constant reminder for everybody. So yeah, it has been a challenge. So that was back in 2014, 2016, the health board did their own spot checks. And then things changed again when we had a single form, which does make life a lot easier. So 5 forms onto one. We now have a range of doses, because we don't have to have the different doses for the different specialties. We now have, and we also have, you can't really see on there, but we have a lovely box, which what dose to prescribe at what weight. So if you've got the extremes of weight over 100 kilograms and those under 50 kilograms, we also have advice if you've got renal impairment. And also we've got on there our intermittent pneumatic compression devices that, again, if you're contraindicated for low molecular weight heparin, we do try and promote that we use that as a second line. I talk about how we're doing this from my hospital's perspective, but I was also very fortunate. One of the clinicians I was involved with in medicine who was quite taken aback about the lack of risk assessments, was Dr. Phil Jones, who was he retired a couple of years ago, but he was the lead for stroke across the whole of Wales. And he's the one that actually had flotrons or IPCs administered for all stroke units across the whole of Wales. So he took this on seriously. His patients were at high risk, and that was one of the priorities to reduce the risk of thromboembolic disease for stroke patients, not just for our hospital, not just for the health board, but across the whole of Wales. And I will never forget him saying that there's two things at that stage that would make a massive impact for stroke patients, is that get them to a stroke unit so they get the appropriate care, and have the IPCs on to reduce their risk of VTE to improve outcomes. So, so we have that now on our form and standardised, and obviously an acute stroke is a contraindication to thromboprophylaxis. So we had hoped that having one form would be straightforward. We do have a slightly different form for those with COVID, and the guidance keep changing, but the vast majority of patients need to have this VTE form. And the other group of individuals, so I've talked about obviously bronchitis and stroke, but also I am very fortunate being an orthogeriatrician, is that I work with a lot of orthopedic colleagues who have taken this incredibly seriously. They take it very personally when they lose a patient because of a pulmonary embolus. And the three consultants I work with here have been very strong in promoting use of thromboprophylaxis and also for limb immobilization in A&E. But I'm also lucky in that we talk about the health board as a whole. So the trauma and orthopedic team is one of the departments where we have 4 hospitals scattered over a vast geographical area, and they work incredibly well together. And I've sat in their M&M meetings, and I have to be honest, it's one of the best M&M meetings I sit in that they genuinely want to learn from each site how to improve things and how to avoid any complications, any cases where there's been concerns raised. And they have been taking on the thromboprophylaxis prescription assessments across the board very, very seriously. And that's one team that work across all 4 sites, because it's challenging when you have 4 hospital sites that do things differently. And although I can talk about bronchitis, and I've been doing this for many, many years now, working with individuals, I don't have the same impact because I don't work on the other 3 sites where there's a different approach. So in the last 18 months to 2 years now, we have bi-monthly meetings where we do learning from events. There is a lot of work going on about ensuring that prescribed lemonade heparin is administered, that risk assessments have been are done, and if we do have any cases of thrombosis, we can present those cases and learn from events. And certainly that's one thing that has impacted across the health board. And again, I'm lucky. I have 3 orthopedic consultants who are very proactive, and my baseline ward, which is majority orthopedic patients but also surgery, was found to have the highest completion of risk assessment forms in the whole of the health board, because it's now common practice that every patient has to have a risk assessment done. But I've been doing this for 10 years, and it's taken quite a while to get this where we are. And Emma's had the challenge of trying to, how can we replicate this across the rest of the health board?
So I'll try and tell you a little bit about how we're trying to do that now. So like I said earlier, I came into post in 2021 in the December. And the biggest part of my portfolio is to do the investigations for the hospital-acquired thrombosis. And on that investigation form, there is this little box that says, was there a risk assessment present, yes or no? And the more I was doing, the more I was realising that I wasn't actually seeing these risk assessments, and I needed to get out there and I needed to find out why. I think we've talked a lot about challenges in terms of kind of human factors, but I think one of the biggest challenges for this risk assessment is that it was launched in January 2020, and then we very quickly went into COVID. So I think that has had a massive impact on how we've been able to launch this document from the word go. And just up here are some of the comments then that we were having from junior doctors. So there weren't any on the ward, didn't know they were mandatory, they use the drug chart, or they risk assess in their head, they're getting lost, there's not enough time, and there was a lot of feeling around they needed the patient's weight to prescribe, and the weight wasn't being done. So from my point of view, one of the first things I needed to do was try and make this risk assessment completion as easy as I possibly could for the clinicians. So this is kind of what we've been doing since I came into post, and kind of leading on from the work that Annette started. So we wanted to have a look at a picture across the health board of what we were doing in terms of VTE. And when I kind of put a call out for audits, lots of audits came in from lots of different people who were kind of working in silo and not really being able to get off the ground with any results they were found. So we looked at the NICE Quality Standards 201, the 5 statements in relation to VTE, and we've developed a suite of audits that incorporate those questions. Because they're measured against NICE guidance, we've been able to upload them onto the AMAT system. So they're registered, they've got their own numbers with the health board, and they're completed annually. So the audit team will reach out to junior doctors now that need to complete an audit and try and get them on board with the completion of that. And they involve medical, surgical and T&O patients. We now have started weekly monitoring of risk assessment completion on all medical admission areas across all 4 sites, so we can then come in and help where kind of compliance is falling down. We've put together a presentation on the importance of VTE risk assessments for our junior doctors, and they received that on induction, and that's kindly delivered by our pharmacy team. We have updated our SharePoint page. We've got a really nice new SharePoint with all the documentation that they will need, and any information around ongoing work and kind of call for help with audits. We have our risk assessment in paper version, but it's also available on Clinical Portal. And we've had doctors then who've taken part in audits and QI work go in to present their work at whole hospital audit meetings. Myself and my team, we try and elbow our way into any kind of board rounds, huddles, medical education, anyone that will open the door and let us in, really, where we're waiving our risk assessment and trying to promote that. And then we've got some QI work going on some sites. So on one site, we're reviewing the medical clerking pro forma, and on another site, we're introducing yellow folders. So the idea behind the yellow folders is that all medication related documents will go in these folders, and they will be kept at the end of the bed, and the risk assessments are kept in there as well. And we hope then that will try and reduce the loss of the risk assessment during the patient's journey around the hospital. I attend governance meetings, and they're bi-monthly, and I feed back our HAP data and our risk assessment compliance data into those meetings. We're nearly there with our adoption of the always thromboprophylaxis policy. It's going to the review board now on the 8th of June, so that should be up on the SharePoint within the next kind of 6 to 8 weeks. And thanks to Andrea and all the hard work of the All Wales team, we've now got our e-learning modules, so we're working hard to promote them across the health board. We utilise the Thrombosis UK patient information leaflets. They're available on the wards for staff and patients. And like I said, we're doing quality improvement projects across all sites. I was fortunate enough to present to the exec team back in March, and we do have a really good exec support now. So it has to be a kind of bottom up and top down approach that we're doing. And then we go back to our, we have thrombosis group quarterly. So I have a rolling agenda item there, and I'm able to escalate any concerns that we've got. I can't talk about the work that we're doing without including pharmacy. We have a really good relationship with our pharmacy team here in Halvar across all 4 sites, who are really robust in picking up prescribing and dosing, and really good at prompting the doctors to complete those risk assessments. And then we've got support from clinical teams. So Annette, I couldn't do my job without Annette. She's really supportive in driving this forward. And again, without going back to our orthopaedic friends, the orthopaedic clinical lead has been imperative in driving this work forward. And then the final kind of piece of work that we've done is we now have a redress review group. So any of our preventable hats go to an MDT group where they're reviewed widely and decided whether we need to go forward with redress. Okay, so talking about those audits that we did, these are our 2022 results for our inpatient audit, which covers quality standard statement 1 as to whether the patients have had thromboprophylaxis prescribed within 14 hours. So that's the nice question. And as you can see, we're nearly 98% compliant there across the health board. So we haven't really any concerns around patient safety in terms of prescribing, but that audit consists of around 30 questions, I think, doesn't it, Annette? Yeah. Where we're going into the risk assessments and have they been completed and to what extent, what areas have been left out. And as you can see, there's still some work to be done now. We're at 47% compliance across the health board, and we're due to start the audit results again now for 2023. But that result is propped up by Bronglice. As you can see, we did 2 cycles in Bronglice and they were 80% compliant with their risk assessments across those 3 specialities for 2022. And looking at the weekly monitoring that we're doing, I think we'll be touching 100% compliance for them for 2023. So really proud of the work that they're doing here. A huge part of it is the engagement from the team. I've already had 5 junior doctors approach me wanting to do the 2023 audits. We have a Teams channel for that so that the audits are on there. They can go with like an iPad and complete them live as they go. And again, in terms of the prescribing, you can see that they're reaching 100% prescribing. So in terms of the other sites, are we making an improvement? So this chart is looking at one of our A&E departments in another site that we've got. This relates to our medical patients who have had a decision to admit, but maybe in A&E for a few days before a bed is available on the ward. And what I found recently is a new common thing that's coming through is these patients are having a slight delay in the thromboprophylaxis being prescribed. So what we've done is we've stapled, I know it should be a standalone document, but we've stapled it into the medical clerking pro forma to see if that improves compliance. So we're not quite there yet. We've got a median of 40%, but we have hit 100%. So we know we can do it. We haven't done so well over the last couple of weeks, but there have been challenges in A&E over the couple of weeks. But we attend every week. We're speaking to the doctors, we're speaking to the nurse and pharmacy teams, and we're attending those huddles. So what next for us in Halvar? So we are hopefully moving on to electronic prescribing, and we have a lead pharmacist who is driving that forward along with our medications nurse and the team around that. And we've asked then if we can have an electronic risk assessment incorporated into our e-prescribing. So we won't be able to prescribe until we've completed that risk assessment. We will continue to support Andrea and the All Wales HAP group with having something on the WNCR in terms of risk assessing for thromboprophylaxis, and that's really exciting if we can get that on. And then we are going to have a big relaunch on the risk assessment within Halvar. So like I said, the policy is just about ready to go, and we've got the e-learning now. So we're going to combine that, and we're going to do a hard launch of the policy across Halvar and see if we can increase our uptake. So lots of challenges, lots of human factors involved. It can be a lonely place sometimes, and Annette and I were kind of thinking of how we sum it up. So we've got a little bit of a video to show you. It's about 2.5 minutes long, but you probably all agree this is kind of
how I felt for promoting this in Bronglize and how you're feeling it for the health board, and I'm sure how many of you feel about it, trying to get people.
I can't see anything, Emma. Don't know if it's not sharing, but
oh, It's not showing.
It's not showing. Okay.
Perhaps you could use instead.
That's okay.
Right,
we'll come off that.
There doesn't seem to be a link in it, though it's underlined. It doesn't seem to be the link there when I've looked on the slide.
Okay.
Okay. Okay. It's a YouTube. I recommend looking at it's leadership from a dancing guy. So basically, just to sum up, it's just how we feel. Sometimes it's a lone person dancing at a concert, and then it describes how other people and sort of the next leader coming on and groups and how you get everybody to dance and things generally. So it's something I recommend having a look at, having seen that, because that is sometimes you feel you're the lone person trying to get everybody on board. And yeah, it's worth it because I'll describe how to do it. And to sum up, so it starts off with one person, then you get a few others, and then basically you get a whole
You've learned a lot about leadership
on board.
and making it work.
Yeah.
And let's watch a movie.
Oh, sorry, start up again. Sorry, apologies.
It's doing its own thing there. Sorry.
So yeah, but it's something I think that all of us have felt at some point when trying to get something implemented and all the challenges, and you feel like you're the only one sometimes. But no, I'm lucky. I mean, I know, and I've had Emma, and then obviously you've got junior doctors in the orthopaedic team, and they have been key. So certainly, I mean, what have I learned over the last 10 years in trying to promote it? It's just, you've just got to constantly promote completing risk assessment forms. I think from the audits having started at the beginning and then being taken over essentially, I think we're more successful because if you get doctors and the prescribers who are prescribing it to get engaged, you're more likely to implement change rather than just tell people that you're not doing it. And I think key for us, as well as that, we've got some junior doctors that are champions. We've got one doctor that actually, because he happened to have an interest in haematology, but we got him to join the thrombosis committee. And I think it's important in your thrombosis committees to hear a voice other than, you know, on the ground. And that's where I kind of came, because I started with this audit. I also did audits on bridging, but I seem to be one of the few clinicians that actually going back to the committee going, but this is what's happening on the ground. This is what's happening. This is what clinicians like, don't like. This is they don't know about these new guidance, even though, because you get bombarded with global emails all the time. It's so knowing what guidance is there, making sure everybody is aware of the latest guidance is important. So yeah, we've had junior doctors championing things, joining the thrombosis committee, being part of the audit, and in fact promoting the ESR module as well, which has been brilliant because you get one doing it going, oh, it's easy, it's straightforward, and then straight on the WhatsApp, come and do this module. It isn't just an individual thing as well. We've already mentioned, obviously the QI team have had a lot of work promoting things across the board, but our pharmacists are our safety net. They with prescribing. And I'm also going to say our nursing staff, I'm asking our nursing staff to start challenging when they haven't had a risk assessment. We use the yellow folders. We've had them for a couple of years on my ward, which works well, because when you adjust the doses, or particularly after surgery or orthopedics, people are bleeding, it's nice to have the risk assessment there. So that, you know, you can write on the risk assessment or just going, they're bleeding, therefore they're not having this today, or when there's changes in circumstance, or when we get weights and things, it can be adjusted. Personally, I think the biggest game changer to make sure this is considered as a priority is when we get our IT systems up to place. I know of colleagues in England where you can't do anything unless you've got a computer that you know, you've done your online risk assessment. You can't get access to certain things until a risk assessment is done. We don't have that, but I think it's something with the plan for the health board is hopefully to have an electronic drug chart within the next couple of years. And it's not just this. I think you know, we do thromboprophylaxis, but it's just as important for other things like our antibiotic prescribing and reviewing at 48 hours. There's a lot of hope that if we can get a good IT system, that we can potentially make sure it's focused a bit more and make sure everybody is aware. But in the meantime, it's just constant reminding, and it sounds awful, but even my weekend on call, I do get a bit frustrated with the changeover with doctors. I will go around and make sure and remind everybody they need to do it. And if it's not done, I do it on my post-take wardrobe. And I ask my colleagues to do the same as well, to review things. So it's never ending. It's every rotation, certainly every few weeks, reminding everybody it is a priority. And dare I say it, it's now with the risk that if you're not following guidance and completing risk assessment tool, that actually there's going to be potentially worse implications in the future if you don't do things properly. They're there for a reason, they're there for safety. It was suggested back in 2011 that this needed to be done, and we're still struggling in some areas to get this done. So it's an ongoing battle, but we'll get there.
We will get there, and we
well,
will.
Thank you very much for that excellent presentation. It's really good to see that you've engaged with orthopaedics, who they're a bit like Marmite. They either they're in or they're out, and it's really good that yours are in, because that's a major challenge. And let's not go back to the 5 coloured forms, because
absolutely
we all remember those, which is well, yeah, they're very colourful, but oh boy, were they hard work. Anyway, Thank you very much, ladies. Really interesting. One quick question, and I suppose I should answer this, but it was directed for you. Should we be auditing thromboprophylaxis within 14 hours, or is 24 hours more realistic? So
yeah,
over to you.
The guidance was 14 hours or within the first consultant admission, but generally speaking, when we go out onto the ward, in terms of, because it's difficult with times, because people very rarely will write times, so we do look in terms of dates for a 24-hour period. So anything beyond the next date, then yeah, we'd be looking at.
I think from my end, I think it's not a question of giving it within 14 hours, because that does not work for key patients. And I will say that for my patients as orthogeriatrician. So if you come with a hip fracture, you do not want to be given thromboprophylaxis at 8 in the morning, because that will scupper any surgery, any spinal. So we routinely prescribe it for 6 in the evening, or sometimes put the box for 6 hours after surgery if they've had it. So I think if they come in before, from my end, if they come in before 6 o'clock, and there's no obvious contraindication, or you're waiting for a CT scan, or from the medical side of things, really most patients get prescribed it for 6 o'clock in the evening, which means if you come in at 8 o'clock that evening, you wouldn't get it, and you'd get it within 24 hours, but not within the 14. But given the specialties, I think it really should be within 24 hours. And you know, again, most patients within 14 hours. It depends what they've come in with. A lot of my patients will be getting or fracture.
Yeah.
So I think we have to be practical about timing, and I think that's where maybe that guidance within 14 hours is not appropriate, because you're not going to give any surgical or orthopedic patient wanting surgery laminectomy happen within 14 hours if they're going off to surgery within you know, the next day.
Okay, well, thank you for that. I'm now going to hand over to our last speaker, last but not least, who's Rhianwen Griffiths, who's been very patiently waiting to give her talk on guiding patients through stopping or reducing their anticoagulation treatment. So Rhianwen is lead nurse for thrombosis, anticoagulation and thromboprophylaxis in Ysbyty Gwynedd in Bangor. And I'm handing over to you now, Rhianwen. Thank you very much.
Thank you. Get these slides sorted. Is that okay? Can you see the slides?
Yeah, that's fine.
Okay, hi. So yes, I'm Rhianwen Griffiths. I'm the lead nurse for thrombosis, anticoagulation and thromboprophylaxis at Gwynedd in Bangor, up in North Wales. So I'm speaking to you today about how our thrombosis clinic, we guide patients through to stopping or reducing their anticoagulation treatment. This is done at a follow-up appointment in our end of treatment clinic. So where and when did the need for this end of treatment clinic come from? We reckon we've been doing some sort of end of treatment clinic for at least 20 plus years, and it was service and patient driven. So back in the days of our massive, large warfarin anticoagulation clinics, either our in-house dosing system would flag up for us any patients that were coming to an end of duration, or our patients would remind us that they were to finish. We would have a quick chat through the clinic door or a phone call to the end of clinic. We would confirm with them that they were to stop, and we would have answered any questions they might have had. Patients would have been discharged just by being discontinued off our dosing system, and if any information was sent to GP surgeries, it was very hit and miss. This was an inherited service that passed down to us from SHO, from the ward, doing it on a rota. So there was no consistency, there was no routine, and there was no ownership. So very quickly, once we became nurse-led, the penny dropped that we needed to do better, as there was so much more we needed to do and improve. From improving the information and how we delivered this to our patients, to improving communication with GP surgeries. During this time, we also started doing the DVT outpatient service. Our end of treatment clinic was started. The process became more official. We would stop telling patients to stop through the clinic door, and we would send out clinic appointments. Patients would be seen, discharged, and information of stopping would have been forwarded to their GP surgeries. Still at this time, most of the information we were giving to our patients was just general. We'd be reminding them to keep active, mobile, take breaks when travelling, keep hydrated, look after their legs, and to see GP and attend an emergency department if they had new signs or symptoms. Running the clinics has started to give us a feeling of completion, that we were coming a full circle with our patients. We were seeing them from the diagnosis all the way through to finishing. I don't think at this time we anticipated how important in the future these clinics would become, or how our role really would expand in this area. Now, before patients can attend our current end of treatment clinic, they will be well known to us. Many will have had previous appointments before having taken place. They may have had their DVT diagnosed with us and they're commencing anticoagulation treatment with us. Some patients will have their VTE diagnosed elsewhere, such as during an admission, from an emergency department, from our SDEC, or even at hospital. They would then have been referred to us on discharge for follow-up and management. We provide nurse review clinics, and patients are seen at least once after their diagnosis or follow-up. Patients have open phone access and further reviews as needed. Following on from these nurse reviews, all patients are seen by our consultant. When this happens depends on clinical need and guidelines. So just to recap, the route to our end of treatment clinic for patient follows on after our clinic review. So one of the decisions to be made from this consultant review, and probably one of the hardest, is the intended duration of treatment. Do we stop anticoagulants or do we continue them indefinitely? It's a very big question. Long-term anticoagulation for secondary prevention is now rightly given as much thought and input as the original diagnosing of the VTE is. So this has had an impact on our clinics and has increased the number of appointments and consultant and nurse times needed in our service to provide these much more in-depth reviews. This also reflects the increased number of referrals over the years and demand now on our service. So our consultant clinic has now gone from 1 clinic a week to seeing 6 patients to 3 clinics a week seeing 10 to 12 patients. So on average, we're seeing, the consultant is seeing 3 to 4 patients in its clinics a week. If we had continued at just providing 1 clinic a week, then our patients have been waiting quite some time and we'd have been out of guidance and frameworks that have been seen. So deciding to stop or continue in anticoagulation therapy indefinitely after completing the initial treatment period requires balancing, as we all know, between the long-term risk of recurrent VTE against the long-term risk of major bleeding. The decision in some scenarios is easy. Example, if you're stopping first stopping after the first VTE, which is provoked maybe by major surgery. But in other instances, it's a very challenging decision, and it can become a tight trade-off between the two. So, how is this decision made? How does our consultant make it, and what's available to help? Well, NICE Commons, tools currently available to predict the risk of reoccurrence of VTE or the risk of bleeding are not sufficiently accurate or validated to be used as the sole basis of a decision, as using them in such a manner might result in incorrect predictions and subsequent harm to the person. However, they also agree that in certain circumstances, a clinical prediction tool can be used in discussing with patients. So maybe the best tool we have is our knowledge, experience, and drive to do the best for our patients. So I've just downloaded and copied a few of the tools that we might use in our different hospitals and areas: the Hasbled, Dashscore, Herdu. There was a really good talk yesterday and presentation, and was much more in depth around the risks and decision making to stop or continue. This was done yesterday by Dr. Rachel Hunter and Dr. Edward Middleton. They based this around a case study and the different scenarios for their patient, helping him to make the decision to stop or continue. And if you didn't catch it yesterday, it's definitely worth a watch. We need to take into account the patient's preferences, the clinical decision, situation, and involve the patient in the decision-making process, especially in cases where the risk of VTE recurrence and major bleeds are very similar. Patient preference and patient decision could be the deciding factor. The discussion between the consultant and patient might involve the use of decision aid tools to help the patient understand the risks and benefits, so they can make an informed decision about continuing or stopping. This has now become a far more complicated and challenging process for our patients than that quick chat that used to happen through the anticoagulation door. The use of DOACs has changed anticoagulation management in lots of ways, and especially when it comes now to times of stopping or continuing. They give us scope to use a lower preventative dose when able. Again, though, this is a difficult decision because of the uncertainty with regards to the estimates of efficacy and the safety of anticoagulation options. But has this been a good thing? Or has it allowed us to keep patients on anticoagulants that we may have taken off in the past? So by the time the patient's journey pathway brings them to the appointment in our end of treatment clinic, a lot of discussion and thought has gone on from that initial diagnosis of their VTE. With individual outcomes for patients having been decided, and they could be that they're stopping, continuing long-term or full-term on full dose, or continuing on warfarin, or they're continuing long-term at a reduced dose. If this is happening, we try to keep patients on their current anticoagulation treatment rather than changing it, because they're used to it and they feel secure and they're doing well on it. The appointment in the end of treatment clinic may well be 3 months from when the decision was made at our consultant clinic. So we recap through their journey, reminding them of the outcome that was decided between themselves and our consultant, and base the consultation around this decision. Sometimes it's straightforward, nothing has changed, and the initial plan will continue. Sorry, I just was in the slide to be with you now. Sometimes not, and the decided upon plan will need to change. We may decide to continue on for another 2 months and re-review. For example, the patient may have had a recent injury, or they may still be getting over the reasons such as a fracture or post-surgery where the VT was involved. We may continue those patients on for another 2 months and re-review. Patients may have had a new diagnosis made, or they've started to go under investigations for maybe cancer, and making the decision to stop or continue is now become again questionable. Patients may have changed their mind as well. So we would put any of these patients back in for review with our consultant. We educate for prevention regardless of the decided outcome. So for those patients staying on long term, a full dose or continuing on a reduced dose, we recap all the good practice according to whichever anticoagulant they may be on, reminding them of bleeding risks and what to do if they have any issues. For those patients stopping, we explain and remind them that they are at a higher risk of developing a second VTE event, and that changing their habits or having some thought in the future may help in preventing this from happening. So the information and education we give is based around travel, sitting for long periods of time at computer desk hobbies, hospital admissions. We explain about thromboprophylaxis, illness at home and what they can do to help themselves, general health, starting new medication, especially hormone-based medication. We tell patients to, if they're starting any medication at all, to remind whoever's starting that they've had a clot in the past. We go through things with pregnancy, post-phlebitic, post-thrombotic syndromes. We go through stockings if they continue wearing them, and we recap on signs and symptoms, what to look out for and what to do and who to contact with any issues. It's important that patients know about all the risks, as many only consider the reason for this event, the reason for this clot that they've just had, as their risk. We remind them that they're at risk of VTE from all the risks. We give them written information, and before discharging our patients from our clinic, we want to ensure that they're as confident as possible with the decision that they've been made, and they are educated as much as possible for reducing and hopefully preventing reoccurrence. Thank you for listening.
Thank you very much, Rhianwen. That was excellent. Lots of food for thought there, and it's a really important area to cover. Big decision for patients to actually decide whether or not to stop anticoagulation, and certainly patients who have started on anticoagulants a long time ago, who have sort of slipped under the radar and are continuing with anticoagulants. It's really good that you review those patients and work with the patient and the consultant yourselves to help the patient to make a decision based on what they want and the clinical situation. Sometimes patients see the anticoagulant as like a safety net, and they don't need to be on it, but they don't want to come off of it either for fear of recurrence of a VTE. So that's excellent, and well done for that work. We don't seem to have any questions. So if anybody's got any questions they'd like to send through to any of our speakers, we have a couple of minutes, so please feel free to do that. Otherwise, is there anything you'd like to add, Marilyn?
I was just going to ask Rhianwen, have you audited since you've introduced a sort of end of treatment clinic?
We audited it right in the beginning when we started it, just to see, well, we thought it was a good idea.
Yeah.
But, we obviously wanted patients to buy into it, and we wanted to know if we were doing what they wanted. So right in the beginning, we did audit it. We haven't audited it later on, you know, more sort of presently, we haven't done it. But maybe it'd be something we could look into, yeah.
Okay. Because we're doing something very similar down here. I think we've had this conversation, but we don't do it face-to-face, we do it on the phone. But I think it's a great idea, helps address those concerns and worries that they have.
Yeah, we did do it face-to-face over the COVID period. We didn't stop. We still carried it on over the phone. But we found that, and some patients, to be honest with you, if somebody DNAs and they're not turning up to this end of treatment nurse clinic, we will contact them by phone. We'll get hold of them and just run through things. If it's a simple one, maybe the patient feels they don't really need to come. They know for definite they were going to finish in 6 months. But we do try and get hold of them and even post the information to them.
Oh, that's excellent. And Joe has just posted that Thrombosis UK has launched 3 new patient information films this week to share information on anticoagulation, stopping and starting complications. So that's perhaps something that you could have a look at, Rhianwen, to you know, have a look at what their videos are showing and what you're doing in your clinics. And it might be something that you can even use perhaps, you know, with the patients to help them come to that decision. I'm not sure what the content is because I haven't actually seen them, but for everybody, it could be useful to have a look. So anything else from anybody? Well, all it needs for me to say then is to remind you all to have a look on the virtual platform, the lounge, the meeting rooms, and see what's going on. If you have any colleagues who you think would enjoy the conference, get them to sign up and, you know, come and have a look at what's happening. You can view the videos up to, or the presentations that have gone and that are coming up till the 31st of May. So if there's anything you've missed, you can go back and have a look at it. And well, thank you very much to all of our speakers today. I think it's really interesting and exciting, the work that's going on in Wales, and knowing that there's going to be more work and changes in the future. So thank you all to you all. Thank you very much to Thrombosis UK for giving us the opportunity to have this showcase event this morning for what's happening in Wales. And thank you to Marilyn, my co-chair, and I hope your voice gets better soon, Marilyn.
Thank you.
And to Joe Jerome at Thrombosis UK. And it just leaves for me to say thank you very much and goodbye.